Well, it is 10:30 and we don't want to deprive your grandchild of you. So I will introduce Dr. Erin Bigler, who is an emeritus professor of psychology and neuroscience from Brigham Young University, who served as chair of the psychology department there from 1996 to 2002. In 1990, he established a brain imaging and behavior lab at Brigham Young University, which studies the role of neuroimaging variables in cognitive and neurobehavioral disorders, such as traumatic brain injuries, neurodevelopmental disorders, including autism and learning disabilities, anoxic brain injuries and other acquired injuries of the brain, as well as aging and Alzheimer's disease. He's an adjunct professor of psychiatry at the University of Utah and volunteer professor of neurology at the University of California, Davis. In 2013, he was the founding director of BYU's Magnetic Resonance Imaging Research Facility. So I introduce you, Dr. Bigler, who's going to talk about concussion research in pediatrics. And thank you for coming.
Great, thank you. For those that were listening in during the break, I just wish I were there in person. I so enjoy my associations with the University of Toronto. And in part, some of what I'm going to be talking about is dedicated to Maureen Dennis, who Dr. Dennis was just a dear friend and colleague of mine for many, many, many years. And she taught me so many things about the pediatric brain and research design and et cetera. And so part of this is a tribute to her and her work at the University of Toronto. So I get to talk about concussion research in pediatrics. And I'm going to be very complimentary to the Canadian researchers because you folks get it. And I appreciate everything that you're doing to study this problem. So some of you have seen this slide before and have heard me ramble a little bit about history. I got my PhD almost 50 years ago, and I was the lucky recipient of a postdoctoral fellow at Barrow Neurological Institute. And that's me and my wife of 51 years. When I was a little bit younger, you can see that I'm a bit older now. But in 1975, that's when the Barrow Neurological Institute got their first CT scanner. And you can see the amazing quality of one of the scans in the lower right with a traumatic brain injury with major hemorrhage. But if you were a psychologist by training and you wanted to specialize in neuropsychology 50 years ago, there were no real formalized programs at that point in time at the postdoctoral level. And so if, like myself, I was a tag-along psychologist at the Neurological Institute. And I was in the neurosurgery department in the division of neurobiology. And so I was tagging along with neurologists and neurosurgeons. And the chief of neurology concussion was really a benign event. And that's what we were taught. I had, in 1966, as a high school student, I had been knocked out in a football game, had actually spent some time in the hospital because they were concerned, I'm assuming, since I don't remember, that I had significant PTA. So I had experienced a significant concussion. And I recovered and, went on to do just fine. So it made sense that I was taught 50 years ago that, if the recovery happened relatively quickly, that there was nothing to worry about. Well, 50 years later, we have a different version of this, but we still have to contend with this idea that there's nothing there. And you can see this older, this is the first CT scan, but remember, these are 1 centimeter thick slices. And computed tomography, this article calls it computer tomography, it did not find anything with concussion. And some psychologists picked this up, and you can see this statement right here that MTBI is a self-contained condition that resolves quickly without special treatment, a generally accepted conclusion of fair-minded neuropsychologists. So nothing to see here, nothing to do. Why should we even study this? But we know that history quite well. And this graph shows it nicely. I did this a couple of days ago in PubMed in preparation for this presentation. And this tells the story right here. You can see if we put in pediatric mild traumatic brain injury, there's now 1,200 articles, but the majority of those articles are just literally in the last 10 to 15 years. And what was the key here is what happened on 9/11 in 2001. And that these soldiers and warfighters started coming back in very large numbers with symptoms that were persisting from concussion, mild traumatic brain injury. Now, of course, this isn't pediatrics, but it nonetheless was the impetus to start this huge research effort. And you can see how this has taken off. But, and let me, Dr. Tatter, can you see my cursor?
Yes, very well.
Okay, so you can see that it's really just in about the last decade that things have really taken off. And oh my gosh, look at this, a Canadian study out of Calgary and the association that you have in Canada to study concussion. And there's a subset of individuals, including children with mild traumatic brain injury, that have demonstrable changes that can be seen with advanced imaging. Now, it makes total sense that we have to apply these advanced tools to assess this, because if it's mild, it's got to be, in some respects, from a neuropathologic perspective, subtle. Look what, if for those that maybe haven't seen this, look at the finding here. And of course, the reason for doing this research is because millions of children annually are affected by concussion. And when certain areas and pathways are studied, we see these differences. You can see the differences here in the arcuate and in the anterior thalamic radiations. And I'm going to talk some more about why we should be studying these particular areas of the brain. And note, this study is just out, and I love the conclusion here. This is the largest prospective longitudinal study of DTI in mild TBI in pediatrics. To me, this is the absolute key to understanding this. You've got to continue with these longitudinal studies within subject design, the most powerful designs that we have, and we have a developing brain. And now we have to connect the injury with symptoms, with cognitive changes, with behavioral changes. And I'll be talking some more about that. But look what's happening elsewhere. So this also is a very recent article, but it's looking at the white matter structural connectome and using that to predict individual cognitive prediction. Now, we're in this huge initiative that's been going on for 15 some odd years on precision medicine. So the WARE study that we were just looking at out of Calgary. So as important as it is, it's still a group study. And for us to really make some advances here in pediatric concussion, we're going to have to be able to drill down to the individual child so that we can customize treatment, monitor outcome, et cetera. And so this becomes very important. And these aspects of big data, machine learning, looking at the whole network is going to be important. So there's tremendous heterogeneity that we have to deal with. And that's just inherent to this problem. This illustration right here has really helped me and guided me in what I've done in TBI. This is a New England Journal of Medicine. You can see the reference there. But I like to view, if you follow my cursor, I like to view this as the cone of vulnerability. And that cone of vulnerability tells us many of the areas that are most susceptible that we need to be looking at. Also, if you look here in this illustration, the anterior aspect and inferior aspect of the frontal lobe is colorized in red. So it is colorized in red because of impact deformation that happens with acceleration, deceleration, coup, contra coup, et cetera. But back to this cone of vulnerability, the cone of vulnerability begins here at the upper brainstem, in particular midbrain structures, and how the upper brainstem is, of course, tethered to the spinal column, and how it's situated in the skull. And the vulnerability of everything that is shaded here are areas that we should be paying attention to. And so, just like in the WARE study, that arcuate, the thalamic radiations, all of those are in this cone of vulnerability. Of particular importance, and if you want to read some more about this, there's a review article that I published a couple of years ago. It's in Neuropsychological Review, and it's this review of mild TBI. It's mostly adult oriented, so it's not focused on pediatrics. But I love this illustration right here of the complexity of the memory network. And of course, most of us have focused on certain neuropsychological measures to assess attention, concentration, memory, and the role of memory, attention, concentration in terms of executive control, those common problems that occur. And of course, look at this. You have all of these important pathways here. And TBI, in many respects, is a consequence of deformation of white matter structures and their connectivity with gray matter. And then, of course, cortical surface areas are susceptible to the compression and deformation effects of impacting the aspect of the skull. So we need to be always thinking about the neuroanatomical aspects. I love this illustration right here in particular, because now if we come over to this midbrain area and the stretch rotational aspects, and we think about the upper part of the brainstem, reticular formation, the diffuse thalamic projection system, et cetera, and how all of that relates to consciousness, awareness, attention, et cetera. And if we think about that, this is where some of the rotational forces are, but we come over to this ventral view of the brain, and we look at the midbrain here. Well, we can see the uncus and the parahippocampal gyrus here, and just inside there is the hippocampus, and just in front of the hippocampus is the amygdala, and here's the mammillary body. So in one sort of close area, we have all of these brain structures that are very important, in my opinion, in terms of some of the symptom generation that occurs. And so here we have the hippocampus in yellow, the corpus callosum, the fornix, and the thalamus, and these networks that we're looking at here, and how any of those networks get disrupted, then we have the likelihood for a study that is just out, and it's online, and it's open source. And so this study looks at the relationship of, I'll circle back, the relationship of the temporal horn with the hippocampus and the fluid dynamics of what's going on in the temporal horn in terms of fluid biomechanical reaction to trauma and adjacent hippocampal stress and strain. And the hippocampus is likely more vulnerable to shear strain effects because of the boundaries of the temporal horn. And even if you look on the right-hand side, these are subconcussive blows. So of course, we're interested in the accumulation of injuries and what that might be doing and what the subconcussive changes may be. This is a commentary published just a few months ago in neurology by myself and Dr. Alder, who's a neurologist in London. This was a commentary on the study you see below, which is another Canadian study. And this study was looking at midline structures of the brain. Well, midline structures in the brain are extremely susceptible, especially the corpus callosum here and the cingulate gyrus. Those areas of the brain are areas that are commonly stretched, biomechanically deformed in response to injury. But here is the huge problem. And another Canadian study. So you can do these biomechanical studies of impact with brain models, even brain models that are designed using MRI, to then look at the biomechanics of the actual injury and recreate that. And depending upon where the head is struck, depending on where the dynamics are from the injury, every injury becomes unique. And then every individual is unique. And then this is compounded in pediatrics. And I know I'm preaching to the choir and you know all of these things that I'm saying, but it's a developing brain. So now you add this additional dimension of this heterogeneity, and that every brain injury is unique. But now a bigger problem for us, and you can see what I have highlighted in red versus blue. Symptoms versus neurocognitive assessment. There are these large studies here in North America and in Europe, the Transforming Research and Clinical Knowledge, the TRACK-TBI, and the Collaborative European Neurotrauma Effectiveness Research, the CENTER-TBI studies. These are, in my view, beautiful, large-scale, longitudinal studies that start with a baseline from an emergency room and then track these individuals. And what you're looking at on the left-hand side is from the Polander study a few years ago. But what's important to me here are these symptom problems that are common to concussion. Now, this is a combination of tract TBI and center TBI, and so these are adults. But you see the same kinds of issues with kids. But of course, you also have children now that are in school, and how these symptoms and the like relate to school activities. Well, this is a problem for us because these are mostly self-rating kinds of things. As a neuropsychologist, how do we assess fatigue, headaches? We have some measures that hopefully relate to thinking, but we have the ecologic validity aspect of it because we're assessing these kids in a laboratory setting, not a real world setting, not a school setting, et cetera. So here we have this incredible disparity that shows up in the tract TBI study. So in the tract TBI study, they show at 1 year, as you can see in red, that 13.5% of the participants show significant indicators of cognitive outcome being impaired at 1 year. That's a substantial number, especially when you think about how many individuals are injured annually. However, in that same sample, 53% remain symptomatic. So they're still feeling symptoms, but they may not be performing at a significantly impaired level on traditional neuropsychological tests. Now, I'm going to end this lecture being very critical of what we're doing neuropsychologically. So this disparity right here is a huge challenge for researchers. Now, you can see and read this. I won't read it. But also in the tract TBI study, somebody who does not have neuroimaging abnormalities, but in the emergency room, they met criteria for having a CT scan, even with the CT scan being negative. So they're not meeting criteria for having so-called complicated mild traumatic brain injury. They remain symptomatic. So symptoms are very important. And of course, Dr. Tatter has shown us this with the University of Toronto study published a few years ago in Journal of Neurotrauma. So we know to look at these symptoms in terms of somatic, affective, and cognitive. And we have neuropsychological measures, traditional measures to assess cognition, but it doesn't necessarily play out in the real world. And so look at all of these different symptoms. And I'm assuming there's probably been discussion in your meeting the last day or so on how we get at some of this, because how we measure this, these are the things that are really distressing the patient and that are really residual issues. Now, one of the missing ingredients for us goes back to what I spoke about earlier, and that's the biomechanics. So what we tend to do, and if you look at the things that I've published, I do what everybody else does. We define traumatic brain injury, and then we separate it out into some different groups: sports concussion, recreational related injuries, falls, motor vehicle accidents, etc. But then we don't take a deeper dive into that background as to where the impact was. And to try to understand the biomechanics of the injury, because understanding the biomechanics of the injury, as I showed those earlier illustrations, that may guide us in terms of what regions were most likely affected to stress, strain, deformation, impact, and where we may guide some of our studies. And of course, this study right here about looking at computational modeling to predict traumatic brain injury and outcome using neural network theory, look what it does. It looks at the arcuate fasciculus. So the WARE study that we started off with, exactly where one should be looking. And these long coursing white matter pathways are so important to understand. But as I alluded to earlier, the developing brain, what a challenge. And so I'm not gonna, the next few slides are not about TBI, but it pulls in all of my developmental neuroimaging work with autism. And so we're publishing a number of studies now. We started this project back in the early 1990s. And some, as you can see in this graph over here, some of the individuals were very young, 3 years of age. And we've now been following them for the last 30 years. And so they've moved into adulthood. And this is a longitudinal within subjects design. So it's not cross-sectional. And that's a very important thing in terms of a few of the illustrations that I'm going to point out here. So whole brain volume. And there are differences that occur between, you can see up here that this is typical developing and the autism spectrum disorder in terms of brain development and trajectories. But I want you to also look at issues that are associated with longitudinal design, imaging, and this is structural imaging that we're looking at. These are volumetric aspects. So there are these changes in the brain that are, of course, dynamic. And then if you look over here on the right-hand side, they're area specific and region specific. And I could show you the same issue with subcortical areas. I just didn't put in that slide. Let's now move. So there's lots of variability in the brain, and all of us that do imaging, we know all kinds of things that may add to variability. And because we're measuring water in basic respects, things that influence water, time of day, et cetera, all of that influences what you're going to get from an imaging standpoint. Now, what about our neuropsychological measures? So we have these differences that occur in autism related to intellectual and cognitive development. You can see if we just look at full-scale IQ, there are substantial and significant differences. But I direct your attention to this slide over here now. Remember, this is longitudinal studies where we're as careful as we can be in assessing these, and look at these scatter plots that we now can smooth out. But if you look at the individual test data, it goes all over the place. So now if we're trying to study kids and we're trying to use traditional neuropsychological measurements, there's a lot of noise in that measurement. And so that's a particular problem. And we recognize this. These are studies from some very prominent neuropsychologists, and you can read what's highlighted there, that our clinical neuropsychological assessment today does not reflect advances in neuroscience, modern psychometrics, or technology. These are tests that are old and traditional. When I taught my last neuropsychological assessment course in 2018, it was very similar to the first course I taught at the University of Texas in 1977. So we have these measurements that tend to be out of date, and we continue to use them to look at outcome. Now, another Canadian study, this is Keith C.E.T.S, and his group. Leah Chadwick is the first author here. This is a study we published just recently. And we use the NIH toolbox that actually measures speed of processing and some other aspects in milliseconds. And milliseconds are of course, related to brain processing time. And so utilizing this technique, you can read the findings here. There were obvious differences that occurred in our MTBI group. And look at where they were. Deficits in fluid cognition that are most apparent on tasks that combine demands for both speed and executive function. So to a certain extent, those kinds of things should guide us in the tools that we're using. But I really believe that we have to move into something that's probably virtual based, where we can control the environment, but approach a much more naturalistic setting in assessing the long-term effects of pediatric mild TBI. Bringing the kid into the lab and having a lab assessment, that's only going to yield so much information. We need to have some better tools that match the real world and not just our laboratory setting. For example, a virtual classroom where the headset is worn, the goggles, the ear auditory control is there, and you create a classroom where the child is having to do some kind of attention memory task, but now you can control distractibility, you can control what's visually going on, etc. I think there has to be some major changes in the way we go about assessing if we're going to tap into detecting some of the more subtle things. And then of course we have to look at networks. This is also discussed in that review article that I referenced before, along with that illustration. But another Canadian study here, and we have to also be looking at physiologic aspects of what the brain is doing, not just structural, not just connectome and white matter connectivity, but actual functioning and physiologic integrity. We just have to tie that in. And so what this means is what I wrote about a few years ago, that if we're going to approach this problem, we've got to approach it in this multidimensional way where we're going after it in terms of innovative methods for neurocognitive and symptom assessment, structural imaging, quantitative analyses, diffusion tensor imaging, tractography, connectivity, fMRI, MEG, EEG, etc. And it has to be longitudinal, it has to be within subjects design, it has to be where we have some kind of uniform recruitment, and we need to continue with all of the sports concussion research because in sports concussion, we can often have that pre-injury scan and pre-injury baseline testing. And again, my compliments to the Canadian researchers for all you're doing and how you're advancing the field. And it's not just a benign problem. It's a genuine concern. And we need to understand this better at a very basic neuroscience standpoint before we have breakthrough methods in how to treat and hopefully change the trajectory that occurs following mild traumatic brain injury in pediatrics. And I'll end there with my traditional closing slide, that it's always much more complicated in there than what we thought. And again, I come back to the 50 years ago, I was taught there was nothing to see here. Well, there's lots to see and lots that we don't know. So thank you very much.
Thank you very much for a very illuminating talk. Dr. Valera has a question about the cerebellum. She says she feels like it's an area of the brain that's often overlooked and only thought of in terms of balance. Given the cerebellum's known cognitive functions, behavioral functions, do you know of any newer studies looking at the cerebral-cerebellar connections?
Oh, it has to be involved. We published a study a number of years ago in American Journal of Neuroradiology, although it involved complicated mild to severe children. And those cerebellar pathways, especially those that project frontally, and then you have cerebellar pathways that project to the basal ganglion thalamus, and they come through the superior cerebellar peduncle. It's very susceptible to the effects of trauma. And the cerebellum, the mini brain, the forgotten brain, that has to be looked at. It absolutely has to be part of looking at the connectivity. And if you think about it for a moment, especially what we know, what we visualize, especially in sports concussion, are all of the balance problems that we see, sometimes just fleeting, but right after a significant sports concussion. So you know these pathways are being affected, and yes, we need to be looking at that.
Okay, great, thank you. I guess I'll ask another question before somebody else does. You know, we think of, at least in the more neurodegenerative field, we're starting to think about precision medicine because there's so much heterogeneity. And I don't know if you have a solution, as we, you know, most of us do group analysis, but we understand that, you know, we need personalized, individualized medicine. Have you any ideas on how we can move towards that? Because, yeah.
Yeah, I do. I think it's going to require enormous sample sizes. And I think that's kind of what I was getting at. So right now, we have this study design, and everything that I've ever published, I've done it this way. But it's the wrong way to do it. So we're not doing it the right way. So we define that, use some kind of standard that the child meets criteria for having sustained a traumatic brain injury. And that goes into the TBI group or the MTBI group. And then maybe in the supplementary aspect of the publication, we'll say, well, there were so many falls, this was recreational, this was sports, this was motor vehicle, this was bicycle, etc. So we try to define that, but then we don't go into the injury aspect in greater detail. So we probably need to really understand the injury aspect of it, and the initial mechanics of the injury, and then maybe that can guide us a little bit better in understanding the nature of the trauma to that individual rather than at a group level. Because if we went back to the pathway diagram and we look at memory, for example, well, maybe that's hippocampus, maybe that's fornix, maybe that's mammillary body, maybe that's the mammillothalamic tract, maybe it's the anterior thalamic radiation aspect. So so now if we understood the nature of the trauma a bit better, and if we guided some of our, you know, right now I understand when these studies are done, we have to limit what dependent variable we're looking at if we have any chance of getting statistical significance. But we've got to be looking at all of those areas. So that's what's going to require a very large sample size. And then using machine learning, big data analyses, maybe that way we can drill back down. And then I believe we're going to have these very robust automated image quantification methods within the next decade. So you get a scan and much of this is all done. And so as a clinician, you can go back into that data set and maybe guide your analysis with precision to that patient that you're seeing. So that's far-fetched, that's out in the future, that's going to require some huge sample sizes. But I think that's where we could make much better improvement than just trying to do things by seat of the pants, which is what we do now.
Great, thank you. There's one other question about ADHD. Dr. Snyderman's asking, he sees patients who were diagnosed as ADHD as kids and then go on to sustain one or more head injuries that then they fit criteria for MTBI. Imaging wise, do you see any difference? Could that help in the differential?
Yeah, well, so from, you know, the attention deficit, sort of the pure attention deficit disorder case and the neuroimaging studies also demonstrate anterior corpus callosum, some differences in white matter structure of frontal and temporal areas of the brain associated with ADHD. So that is the brain that is then highly vulnerable. And then of course, ADHD kids are the ones that may take chances and increase their risk for head injury. And in the past, if you look at even things that I've published, we tended to exclude children with ADHD in the analyses. Well, we shouldn't exclude any, because if we're going to get to the point with precision medicine, just like you saw those graphs that I showed with autism. In autism, if you look at the gross aspect of the brain, it looks entirely normal. But when you get into the microstructure, it's different. Well, kids with autism spectrum have brain injury. Well, we should be looking at them. Now, Jeffrey Max, psychiatrist at University of California, San Diego, has been doing a number of prospective studies. I've been involved as a co-investigator with him for 25 years. And we published some recent articles where ADHD is one of those novel or new onset disorder, at least from parent review, that the child didn't have, but now has after injury. So attention deficit hyperactivity disorder like problems can certainly emerge from brain injury because it's the same areas of the brain that are being damaged or that are initially involved. And then ADHD is certainly a vulnerability issue when TBI occurs.